Now let's discuss different urinary tract infections one by one, like pyelonephritis. Then you have the abscess formation, and then you have the emphysematous pyelonephritis and xanthogranulomatous inflammation of the kidneys. So talking about the acute pyelonephritis, that is actually the infection of the renal pelvis and the kidneys that usually results from or because of the bacterial pathogens of the lower urinary tract, which are in the ureters or which is in the bladder. I have already explained the mode of spread, or it can be it can be because of the hematogenous infections, or it can be because of the sending infections, right? So hematogenous infections, they're blood-borne. So any focus of infection like carbuncle, like boil, because of the streptococcus or mostly Staphylococcus aureus. And then because of some oral infections like tonsils and dental caries, there's tendency for the hematogenous spread. So it can reach all the way to the kidneys and their renal pelvis and their ductal system, the calluses of the kidneys. So that can lead to the pyelonephritis. And the other mode of the spread is obviously because of the sending infections, which are from the lower urinary tract, like ureters or bladder, and more common in the obviously lower urinary tract infections are more common in the females because of the short urethra. Now, when you talk about the etiology, hematogenous infection from our primary side, it can be tonsils, it can be carious tooth, it can be like cutaneous infections like boil and carbuncle, and then you have the sending infections because of urinary stasis or presence of calculi or vesico-ureteric reflux. So I have explained the tonsils, the carious teeth, and cutaneous infections, and most of the time you have these gram-positive streptococci and staphylococci, gram-positive bacteria in the tonsils and in caries teeth in the cutaneous infection, and there is more of the tendency to be a blood-borne pathogen. And then you have the sending infections because they can be because of urinary stasis. They can be because urinary stasis because there is infection in the ureters and the bladder. It's cystitis, or patient is complaining of uretile colic. Then you have the presence of calculi, again, if there's a stone, so that will lead to the urinary stasis. And then you have the vesico-ureteric reflux. So when you talk about this vesico-ureteric reflux, it has got a primary cause and a secondary cause, right? So primary mechanism and a secondary mechanism. So the primary mechanism is somehow related to the detrosal instability. It's secondarily to the short length of ureter, which is entering into the trigone of the bladder, and which is the short intramural length as compared to the diameter, which needs to be normal is 5:1, but for a VUR, the diameter most of the time it's 3:1. The length to the diameter ratio is 3:1, which is normally 5:1. And most of the time it's common in the children, and there can be some secondary causes to the vesico-ureteric reflux because it can be renal scarring, it can be ureteric calculus or urinary tract infections, and then because of the neurogenic bladder, it can be one of the causes for the vesico-ureteric reflux. So there can be anatomical problems, or there can be some other secondary causes which can lead to the vesico-ureteric reflux, including the infections and neurogenic bladder or spina bifida, and especially in the children. I would be talking in detail when we were talking about the vesico-ureteric reflux. Now, again, symptoms. So it's pyelonephritis is actually the kind of infection of the upper urinary tract. Okay, so it's including the kidneys and the renal calluses and the pelvis. So it's infections. Obviously, the patient will complain about the fever, rigors, flank pain, and mostly in the upper part. So when you have a lower urinary tract infections, mostly the pain is in the groins, the lower part, like, and then it's radiating to the genitals, right? But if it's acute pyelonephritis, then the pain would be limited to the upper part, and that would be flanks like this, and they would be radiating to the back. So remember, fever, rigors, flank pain, nausea and vomiting, it's a sign of every infection. Then you have the costovertebral angle tenderness. So where is the costovertebral angle? It's about the almost 9th and 10th rib, and you perform a renal punch, and it's like if there's a positive tenderness, then you say that it's acute pyelonephritis. Pyuria is almost present in all of the patients. So if you actually catheterize such patients, maybe possible the patient tells you that whenever he passes urine, there's a pussy discharge of the urine, but sometimes he cannot appreciate when you catheterize these patients, you can see the whole length of the catheter, the tube, so there would be a lot of the pus coming along with the urine, so that would be pyuria. And because it's a grave infection, if it's complicated, it can lead to sepsis, and the patient will present to you with in a septic shock. And then because of the long-standing infections and complicated infections, that can lead to the renal scarring, renal parenchymal damage, and that can lead to the chronic nephritis and leading to the end-stage renal disease, or you can say the acute renal failure. Not only the chronic pyelonephritis, but acute can also lead to the acute renal failure because of low pressure. When the patient is in septic shock, obviously, there would be hypovolemia as well, and there would be a decrease in a renal perfusion, and that will lead to the acute renal failure. So renal failure would be secondarily to the sepsis, and it can be secondarily to the directly because of the compromise of the renal function. So remember these symptoms: fever, rigors, flank pain, nausea, vomiting, costovertebral angle tenderness, pyuria, septic shock, and renal failure. Now, how you can investigate such a case? When you talk about the investigation, always start from a very, very basic investigation. So the very basic investigation would be blood CP. You will look up for the TLC count, and you will look for the differential counts. If it more of the neutrophils predominance, or there's a dominance of the lymphocytes. So if it's lymphocytes, obviously there would be chronic pyelonephritis. But if there are neutrophils, so obviously there would be acute pyelonephritis. So then second thing you have to go for is urinary, in which you have to look for the WBC count, you have to look for RBC count, you have to look for proteins, and some other parameters as well. And then the important is like if you should send the urine for culture as well. So whatever the pathogen that comes out to be in that urine culture. Then talking about the imaging studies, you have to go for the ultrasound pelvis, and you can do for x-rays if you see there is a radiopaque stone, you're suspecting a stone, the patient is complaining about ureteric. Remember, ureteric colic is different and renal pain is different, okay? So people use the word renal colic. Renal colic is not the word, it's a ureteric colic, because most of the time the stone is in the ureter, and the patient has an episodic excruciating pain that lasts for some time and goes on its own. That is a typical colicky episodic pain. But in case of the pyelonephritis, there would be dull, a continuous pain that would be radiating, that would be in the flanks and upper part and radiating to the back. So when you're trying to investigate and you're suspecting acute pyelonephritis, go for ultrasound pelvis and the kidneys, and then which is actually the kidney urethral bladder, and then you can go for X-ray KUB, an intravenous urogram, which is a contrast, and it's good you go for a CT scan, which is contrast. It's an enhanced CT scan of KUB, kidney urethral bladder, which will tell you about the status of the kidney, the scarring, or there is a cystitis, or it will tell you about the renal echotexture as well. Then there were some other investigations like cystourethrogram, And most of the time, these are for the anatomical changes. Posterior urethral valves are present or not, vesico-ureteric reflux, and then you have some DPTS scans and DMSS scans, which are most commonly resolved for the vesico-ureteric reflux. But when you're talking about acute pyelonephritis, urine in the blood cultures, send for the urine cultures, the blood cultures, send for the blood CP, which is actually, you're looking for the TLC count, the differential count, neutrophilic and lymphocytic count. And then you have the renal ultrasound, which is important initially, very important investigation. It will tell you about the renal parenchymal changes, if there are grade 1, grade 2. There are different grades for the renal parenchymal changes. And then you have the contrast enhanced CT scan, which is absolutely a very important investigation when you're investigating a case of a pyelonephritis. Okay, now comes the most important part, which is about the management. So you can treat with a conservative antibiotic therapy, or if it's complicated, then obviously you have to go for the surgical drainage. If it's complicated by the abscess formation and the patient is much febrile and you're suspecting that there's a perirenal or cortical or corticomedullary abscesses, then you have to go for a drainage process. So you need to follow the algorithm. So if it's acute pyelonephritis, then see if it's mild, then you don't have to go for ultrasonography. You can just deal it with the antibiotics, conservative treatment. If there's indication for initial genitourinary imaging, if there is no indication, then clinical indications for immediate hospital admissions. Okay, so if there are clinical indications, like the patient is febrile, he's in so much of the pain, his heart rate is high, and then you have to admit the patient to the hospital. If there is no clinical indication, it's just a dull ache renal pain, and TLC count comes out to be normal or near normal, then that's you have to treat your patient as the emergency department patient. So indication for emergency department or observation unit stay, if there's no indication for an emergency department observation or unit stay, then discharge the patient on oral antibiotics. If there is indication, clinical indication to the admission to the hospital, okay, then obviously you need to admit your patient. So if there's an emergency department stay, or treatment, then treat initially with the IV antibiotics and then discharge your patient on oral antibiotics. So if there's a persistent indication for emergency, if the pain is not resolving, he's still febrile, then you need to admit your patient and properly investigate. So admit the patient to the hospital, and if there is imaging need and there is if there is abscess, if you have performed the CT and CT tells you that there is a perinephric abscess or cortical abscess which needs a drainage, then obviously you need to go for a drainage. So remember, if you're suspecting acute pyelonephritis or there is no genitourinary imaging, right, then you can go for hospital admissions, or there's no need for hospital admission. If there's a need for hospital admission, then obviously admit the patient and treat accordingly with the IV antibiotics. If there's no need for hospital admission, discharge, give the immediate emergency department just the emergency department management with the IV antibiotics, and send your patient home with the oral antibiotics. And if there is a need for drainage, then you have to go for a surgical drainage of such patients. And if there is no imaging shows that there is no need for drainage, then you can either discharge the patient or you can admit the patient on oral antibiotics. Okay, so that's the algorithm which you need actually to follow. And you need to decide if your patient needs the hospital care or you can manage your patient accordingly just on the basis of oral antibiotics. So there can be some complications related to the pyelonephritis. There can be papillary necrosis, there can be pyelonephrosis, or there can be perinephric abscesses. For the extensive complications, obviously, you need to open up your patient, or you need to do the percutaneous drainage. I'll be discussing it when I'll be discussing about the abscess formation. So just remember, for the time being, remember the complications: papillary necrosis, pyelonephrosis, and perinephric abscesses are the complications complications which are related to the pyelonephritis, upper urinary tract infection.